So
Yeah.
for treatment purposes, nasolabial fold is divided into three quadrants: the upper one third, middle one third, and lower one
Yeah.
third. The most important point is the upper one
Yeah.
third,
Yeah.
which is also called as piriform fossa, and it is the anchoring point for the entire nasolabial fold. Now it originates from the lateral nasal ala. It continues down towards the corner of the mouth. And it can also be referred to as deep piriform space or restore space, and it is found lateral to the base of the piriform aperture of the skull at the ala of the nose. Now, anatomically, when we see what are how is the space defined? So inferiorly, we have the preorbicularis oculi fat. Laterally, we have the deep medial cheek fat pad. And medially, we have the
Yeah.
depressive nasi muscle. Right?
Yeah.
And this fossa or this space is a potential anatomical opening at the base of this region, and it enlarges with maxillary recession. With age, that means with age, as the maxillary recession is happening, this space will enlarge, and with associate and along with the fat atrophy as we age, this fold becomes deeper. So tear trough and nasolabial fold are otherwise normally also seen, without aging. But with age, their appearance depreciates. So when we are correcting these areas, we do not want complete correction. We are just giving a slight enhancement or slight improvement.
Yeah.
By filling this area, the appearance of the nasolabial fold depth can be significantly improved. Now, first, we had discussed initially also, like, why is this fold happening? Because of the tissue difference in the tissue arrangement of the cheek area and the perioral area. So the perioral area, the fascia is densely packed, and in cheek, it is not as densely packed. So what happens? There is a barrier which is formed. As such, there is no physical barrier between the cheek and the perioral area. But because of this tissue organization, that demarcation is formed, which is why the fat which is with age, the fat which is going anteriorly and forwardly, it does not extend beyond this, because medially the tissue is very densely packed, the fascia and all.
Yeah.
So it has no space to fall more medially.
In this slide, by filling this area, they mean piriformis aperture?
Yeah, piriform. We are talking about the piriform space in this. So by filling the piriform space, the appearance of nasolabial fold depth can be significant. So the moment you do the NL1, which is the first point, upper one third, the entire nasolabial fold will improve. There are multiple improvements that you can see just by injecting the piriform fossa. I'll be discussing in the next slide. So treating this fossa also spares the use of direct nasolabial filler lower down. Sometimes, suppose for my face, if you only do the piriform space, you don't need the NL2 and NL3 points.
Yeah.
Right? So which can otherwise cause unnatural puffiness. Now, what are the benefits? You can see, first of all, it narrows the base of the nose. So when you inject the piriform fossa, the nasal flare, you can see the base of the nose narrowing down. It supports the nasal tip also. Then it decreases the distance between the columella and the upper lip, and it modulates and supports the overlying dynamic muscle of the lip. So there is a muscle, LLSAN, which is called the snarl muscle, right? Like this, when we are doing this now, so it's one head is inserted into the lateral nasal ala and one into the this area, lip area.
Yeah.
Right? So
which
this
is the muscle?
LLSAN, levator labii superioris alec. So this muscle gets support from beneath when we inject the piriform space. So how does it help? It will help in the improvement. And this muscle is responsible for the gummy smile. This is the muscle where we inject Botox for gummy smile. Hyperactivity of this muscle will cause gummy smile. So we inject 2 units each side in the LLSAN to improve the gummy smile. So when you...
This is in piriform fossa? This is in piriform fossa?
Yeah, see, piriform fossa is the fossa on the bone, right? But when we talk about the muscle, it is when we inject the piriform fossa, this LLSAN muscle gets support from beneath.
Yeah. So medial to the fossa is depressor nasi.
Yeah, medial is depressor
And,
nasi.
and and in the fossa itself is this LLSAN.
LLSAN, yeah, yeah.
Okay.
So it modulates and supports the overlying dynamic muscle of the lip region. So steps to inject. What are the steps to inject? First, see, this point is also a little bit, painful. Like as compared to other points, there is slight discomfort in this point. So first of all, you feel for the canine fossa, or this canine obtrusion on the jaw, and medial to it, you have to inject. So first, I'll be coming to the technique later. First, ask the person to take a deep breath, hold it for a second. When they're holding the
Yeah.
breath, you inject and insert the needle. The needle has to be inserted on the bone periosteally. The needle has to face the opposite corner of the mouth. The entry point, the angle should be, it should be angled towards the opposite side corner of the mouth, like this.
Yeah.
So it should be pointing like this, right? So
Yeah.
ask them to take a deep breath, hold the breath. When they're holding the breath, insert the needle facing that way, and aspirate for 12 seconds. Although the artery is superficial over here, but still aspiration is, advised. And then wait for 10 to 12 seconds and then start injecting 0.2 to 0.3 mm is minimum required,
So
right?
we are bolus on the bone.
Yes, bolus on the bone of 0.2 minimum or 0.3 minimum. Heavy phase 0.3 minimum.
Yeah. Fine.
Yeah.
Yeah.
And the thing is, the artery is superficial over here, and you can pass through the artery, but you cannot inject into the artery. Sometimes when you withdraw the needle, there is oozing of blood. So if there's oozing of blood, just do some compression. Nothing to worry, because you haven't injected inside, because the artery is not on the bone.
Yeah.
So just do a compression 3 to 5 minutes, and that will reduce the bruising also. So my screen is visible, right?
It's all mixed up.
Okay, you can't.
Not a single slide, but there's like.
Okay, just a second. Now is it fine?
No, I can't see the screen now.
Okay, just a second. Now?
Yeah, now I can see.
Okay, fine.
Now it is clear.
So now the MD course, that was about the piriform fossa, which is the main thing. So the 3-point nasolabial reshape. The 3-point nasolabial, we have 3-point NL1, NL2, NL3. Again, the sequence of injecting is 1, 2, and 3. Upper nasolabial, central, and lower nasolabial. The three in this, NL1 is an alert zone, because the facial artery is, and the branches to the nasal flare are there. And in Asian patients, the facial artery may lie in the nasolabial fold. So this is how we do NL1. So for NL1, needle, there's a question like whether to use needle or cannula for this. So for NL1, always a needle in Indian patients. Cannula for Caucasian patients, because there is some difference in the pattern of maxillary recession. Second, how can you make out whether the maxillary recession is there or not? So you have to observe the face in profile view. So in profile view, the middle half of the face has to be convex. In profile, it has to go like this. There has to be convexity to the anterior convexity to the face. So
Yeah.
if that is not there, if that anterior convexity is less or is not there, that means you have to inject maxilla. I mean, the maxillary recession is there. It could be due to age. It could be due to, genetic or anatomical formation of the face. Some people have, from birth only, they have slight recession. In them, you can see the upper jaw protruding out. So needle, I would recommend needle is best for NL1.
So the diagram shows the direction towards the opposite eye.
No, diagram, don't
Rather
go
than
for the diagram. These are taken by for the purpose of taking pictures. Because if they would inject like this, then you cannot take a photograph in this view. Because this is what, when these slides come through and we've put these questions, similar questions, like why in diagram it's like this. So that was the answer given to us. Because for the purpose of taking to just see the entry point.
Yeah, fine.
Because here NL1 is totally opposite. I am telling you to face, the needle has to point towards the opposite corner of the mouth. If you're this
Yeah,
thing here, it has to point here. So that is not how we do it.
and also it's not perpendicular. It's almost like
Yeah,
horizontally going.
it's horizontal.
The
So this
subcute
is
plane.
like,
It's like a
yeah,
subcute.
yeah, it is a subcute. This you can do, see, NL1 you can do on the bone, and after on the bone, still you can see some indentation. Then you can do a little bit, 0.1 to 0.2 with needle or cannula.
Yeah.
Right?
Yes.
In NL1, the product of choice that we have is Juvidum voluma, not Volift, if on the bone. So when we are injecting on the bone, product of choice is voluma. Minimum quantity is 0.3. And if we are injecting with the needles into subcu, then it can be Volift. Never, voluma never in the subcu.
Yeah, fine.
Right. So device is needle or cannula, preferably needle on the bone. Delivery is with the linear threading. So this linear threading is with the cannula when you're doing subcute with Volift. Here they have shown Juvidum Volift with a needle or a cannula with linear threading. The periosteal point they have not shown, but ideally it is done periosteally.
No, but it should be bolus.
Yeah, it should be bolus, but in the slide they have shown for the subcute injection. Because see, the structure they were injecting is subcu, it's not the bone. In this slide, they have shown only, that's why I don't refer to the NL1, I mean nasal label. I tell my stuff first, and then you can pick some points from this.
So it is on the bone and it is bolus.
Yes, 0.3 bolus and with voluma.
Fine.
So if I have to give somebody 2 ml fillers, so I will give 1 ml voluma and 1 ml Volift, because with voluma I can do CK points, CK1, 2 and NL1. So 1 ml voluma for these 2 points, and rest I put Volift in CK3, NL2, NL3. That is how I divide my product. Is it confusing? Is it has it become a little confusing?
No, it's clear. No, it's clear to me. I'm okay.
Yeah.
Yeah, it's clear.
So when we do the NL1 with the needle, it reduces the prominence of entire nasolabial fold and not just the piriform fossa.
Yeah.
So we can do it with cannula also, but this is not recommended. Then the central nasolabial fold. For central nasolabial fold, again, product of choice is Volift or Ultra Plus XC if you have. The volume is 0.2 to 0.4 ml, needle or cannula, but linear threading in the subcute. So here, you have to be as superficial as possible, upper subcute, the more superficial you are, the better the result, because the deeper you are, we are trying to support the line from beneath. It's not a line also, it's like a curve. So we are trying to support it from beneath. So if you are deep, that you'll get inject a lot of product without giving enough support. So
So you have to be, yeah, superficial means below dermis.
yeah, below dermis.
So my question is, suppose we can see the groove.
Hmm.
When you are injecting in the groove or injecting on either side of the groove.
Slightly medial, never lateral. Slightly medial to the nasolabial crease. Because the artery, it seems, lies lateral, but then there are so many variations. This is a generalized form, so slightly medial to the.
And how superficial is the artery? What is the level of the artery?
When we start from NL3 to NL1, the artery is from deeper planes to the superficial planes. So there is no one level. So if we see in a what we say sagittal section, if we are seeing the artery, so from NL3 to NL1, it is going upwards.
Oh.
So at the
We
point,
can't define.
Yeah, we cannot define exactly what point the artery is,
Fine. Yeah.
So NL3 point, again, it reduces the prominence. The product is Wolift, 0.1 to 0.2 ml with a needle or a cannula, linear threading, and in subcute. And it again reduces the prominence of the nasolabial fold, injects slightly medial to the nasolabial crease. Now, problem is when nasolabial fold is done, then the accordion lines, the commas here, they become more prominent. So how do you deal with them? So observe them before the procedure itself, the accordion lines, and the nasolabial fold, that fold we are doing linear threading, but accordion lines we should not do with linear threading. It should always be horizontal like this.
Cross hatch. You mean cross hatch?
Cross hatching.
This is Wolift, I suppose.
Yeah, Wolift. NL2, NL3 always Wolift or Ultra Plus XC. Never Voluma, because if you put Voluma, this area is very dynamic, this area has a maximum movement on the face. It's very dynamic. So if you put something very stubborn in a superficial plan, it's going to show up in all the movements and it's going to appear unnatural.
Yeah. So is the accordion line a part of nasolabial?
No, it's not a part of nasolabial, but they're seen along with nasolabial. So once the nasolabial is treated, then the accordion lines become, they start bothering.
Yeah. Fine. And the cross hatching we do superficial plane again.
Superficially, all superficial plane.
So we are just below the dermis, I think, just below the dermis.
Yes, just below the dermis. You can actually see the tip of the needle. So how can you reduce the risk of vascular occlusion when you're treating the pyriform fossa? So this can be reduced by number one, considering the depth of the injection. We know that artery is superficial, so our injection is deep. Aspirating before injecting supraperiosteally, that is aspirate for 10 to 12 seconds. Then inject slowly. This is very important, actually, when we are injecting, we are always in a hurry. So if you inject slowly, you are least likely to puncture an artery.
Yeah.
So always stabilize the needle with the non-injecting hand and then inject very slowly, and most importantly, withdraw very slowly. And when you're withdrawing, remove your thumb from the plunger.
Yeah.
And they say you can use a cannula. I don't prefer a cannula because with cannula, I'm not able to be as superficial as possible. With needle, I can control the depth of the needle and be superficial. With cannula, you end up using a lot of product with less of result,
Yeah.
And
Fine.
use a low pressure while injecting and inject small boluses of filler.
Small versus means micro aliquots.
Yeah, microaliquates. In NL2 and NL3, microaliquates. In piriform fossa, one big bolus, but inject slowly and withdraw needle slowly after you have left the plunger.
Okay.
So if there is oozing of blood, you might have punctured the artery, but you haven't injected into it. So just put some compression.
Mm. So aspiration is possible in NL1, but how do you do aspiration in NL2 and 3? That's a linear threading technique.
Yeah, so you insert the syringe, hold it with a non-injecting hand, aspirate, and then inject. I mean,
Then
you have
keep
to use
injecting
your
and
normal.
withdrawing.
Yeah,
Keep inject and keep withdrawing.
yeah.
Yeah, okay.
So angling the needle up to the opposite oral commissure and not angling upwards. This also makes it a safer technique. It avoids the infraorbital artery territory. And the cannula is again 25 gauge or 22 gauge cannula. Can be used if ever you have to, but 25 gauge is better. But cannula doesn't, the depth, control of the depth is not possible. So,
Yeah.
so this was about the nasolabial fold. So I think we are done with the mid phase.
Yeah.
Anything you have to discuss or ask?
No, I'm clear about it. The nasolabial is something that we started with first, so
Yeah.
it's not a big problem.
Okay, so I want to discuss something on nasolabial fold. Not this. Can you see this chart?
Yeah, I can see.
So this is a nasolabial fold treatment chart. So first you assess at rest. If the cheek sagginess is there, then you have to treat the cheek first, and then come to the nasolabial fold. So this will be probably be there in the senior age group individuals, cheek sagging. Then if there is no sagging of cheek, you can directly treat the nasolabial fold and check the severity. Mild to moderate, only NL1 and LL2 is okay, but if they're severe, then NL1, LL2, LL3. Then second is assess while smiling. So if it is a non-distracting smile, that means it's a normal smile, there is no gummy smile or something like that, then so this assessment of the smiling is done after you have done this first step.
Yeah.
So once you have injected, and after the first assessment you've injected, then after injecting, you assess while smiling. If it is non-distracting, no, nothing is required. If it is distracting, then mild to moderate, re-inject NL1, NL2, maybe in the next session or after 15 days. And if it is severe, again, NL1, NL2, NL3.
So what do you mean by distracting? You mean gummy smile?
Yeah, gummy smile.
So won't Botox be better to give rather than giving more of it?
Yeah, rather than giving, but Botox will last only for a month or 2-3 months.
Yeah, but this is mostly because of LLS, SN.
Yeah.
Levator, labi.
If you have a person who can understand that, okay, with Botox, they might need, every 6 months, then it is fine. Usually the step 2 is not required, but in case,
No, but in case distracting means gummy smile, I understand it's a gummy smile.
Gummy smile.
Right?
Yeah.
So you inject 2-unit Botox in the pyramid fossa?
Yeah. No, beneath the pyramid. You mark out
Beneath
the
means?
muscle. Yeah, over here. You have the lateral nasal ala,
Below.
just beneath.
Yeah.
This point.
So we are not in the pyramid fossa. We are below the pyramid
No.
fossa.
We are in the muscle now with Botox.
No, we are the muscle, but the location of the muscle is below the pyramid
Below
fossa.
the fossa.
And are we going deep down to the bone with
No,
Botox?
superficial, very superficial, because the muscle is inserting into the dermis of the lips and the,
So superficial.
very
Bleb.
superficial. Yeah. Yes, raising a bleb.
Below the anal of the nose.
Yeah. Lateral nasal ala, below the lateral nasal ala, very superficial. 2 units here, 2 units each side. So when you inject NL1, you can see the improvement in the upper lip. The upper lip also becomes slightly everted after doing NL1. So if you've injected with the needle on in the piriform fossa 0.3 0.3 ml, you can easily see the reduction in the nasal flare and the eversion
Yeah.
of the upper lip, medial upper lip.
Yeah. Okay. Got it. Yeah.
So that was about the nasolabial folds.
Okay.
Right. So we have some 10 minutes. If you want to discuss, we can discuss something.
We can take, I think, marionette lines we can take today.
We can start, but
Or
we
I
will
think,
be able to, complete it. Just a second.
no point. Or you can take jaw, the sagging of the jaw. How do you, jowls, how do you work with jowls? I still find it difficult to understand how can fillers work with jowls. I only suggest them liposuction. I
No.
don't know, means how do the jowls really work with
Yeah,
fillers?
yeah, definitely. The reason of jowling, that means to understand jowling, we have to understand the aging of the face. Now, aging of the face, we have the deep fat and superficial fat. Now, the deep fat is deflating, because of which
Yeah,
the superficial fat is losing anchorage and support and it's falling down. And also the superficial fat pads, the upper one third of the superficial fat pads are reducing, and the lower two thirds is gaining more of fat because of everything is falling downwards and forwards.
yeah,
Right. So it is about re-inflating the deep fat pads
yeah,
and re-anchoring the superficial fat pads. So that is how fillers work in, and acha, if there is, they ask what are the other modalities, no? So for nasolabial fold and for malar mound, it is always better to do microneedling RF. It gives a very good result, not by lifting, but by just tightening.
so Malermont respond to RF,
Yes,
microneedling RF.
microneedling RF, yes, it does. It becomes better.
Okay.
So before, if
Yeah,
see, patient to patient, it varies. If they're ready for 6 sessions of microneedling before filler, it's always better to do, because that will reduce the malar mount to a great extent, and then you can continue with the fillers.
yeah, yeah, fine.
So deep fat we have to reinflate, and superficial fat we have to anchor it again, because that is losing anchorage because of the bone resorption. Because the fascia or the ligaments don't age. That is a very, even in cadavers, they are very hard to dissect.
Yeah,
So that is how fillers work. So wherever there is bone resorption, we are injecting on the bone. And wherever there is soft tissue shadows that are forming beneath the ligaments, we are just
yeah,
doing some filling. And jowling is basically when we do the lower face pat pads, they are again, falling forwards into the, this is the pre-jowl sulcus. So what we are doing
yeah.
first, we are doing the lateral points for anchoring. And then we are filling the remaining points.
Okay.
Let's start at macro lower face. So mandible is the largest and the strongest bone in the face. It has a mental protuberance of the, there is a mental protuberance, and then there is a mandible bone when we see the lower.
Yeah.
Muscles of importance in the lower face, chin, and jaw region. They are depressor septi, orbicularis oculi. Then there is the modulus, which is a very important point where all the muscles are converging, and also the periocular muscle is there. Then we have the depressor labia inferioris, mentalis, zygom, all the smile muscles, masseter, risorius. Risorius is very important muscle because it's going horizontally like this, and it's very superficial. And DAO.
Yeah.
DAO again because the angle of the mouth is there. So again, this is the smash that we've done. Retaining ligaments for the lower face. First is the platysma auricular fascia, then the masseteric cutaneous ligaments, and then there is a mandibular septum, right? So
Yeah.
when we are injecting the lower face, when subcute, we are putting voluma. This is a place again where we put voluma in the subcute in, a fanning pattern that is to tighten and, to give anchor to the masseteric cutaneous ligaments. And after we've done these points,
Yeah.
then we inject hair on the bone before the mandibular septum to cover up for the shadow, remaining shadow that is there. That is forming the jowl. So injecting into the pre-jowl sulcus.
When we're injecting the pre-jowl sulcus, we are actually supporting the masseteric
Ligament.
cutaneous ligament.
Yes, yes. We are not supporting. We are just the shadow that is being caused by the ligament. We are trying to compensate for that shadow just by filling it from
Okay.
pushing from behind.
Okay. Yeah.
So aging will cause loss of subcutaneous fat from many facial pads. These are the middle face. This is the artery. So aesthetic principles for female face. Attractive, youthful females have an oval shape with smooth, gentle, unbroken curve from temple to the outer borders of the mid and lower face and down to the chin. And this is universal to the all races. And so angle of beauty that we can calculate, we don't usually do it, but still for, theoretical purposes. Draw a vertical line at the angle of the mandible. Draw an oblique line from the lateral aspect of the cheek to the mandible. So one is the angle of the mandible and lateral cheek to the mandible. So the angle at the intersection of these two lines should be 9 to 12 degrees. That's what they say.
Okay.
So a beautiful jawline. So why people are concerned about their lower faces? Because the perception of beauty has changed post-COVID. We are looking at ourselves more often, and that too in the profile view and selfies and more. So the jawline is more visible. And prominent jawline is what people are asking for nowadays. They need a, jawline.
Yeah.
So the beautiful jawline is there is a sharp demarcation line between the lower face to the neck, and the horizontal and vertical outline connected by a sharp, gentle curve at the angle of the mandible. A gentle silhouette just below the jaw onto the neck. A continuous unbroken line or curve from the mandibular angle to the chin. So this is actually broken.
Yeah.
It has to be smooth. If not angular, it has to be at least smooth.
Yeah.
The chin should be an oval shape resembling the taper. So while injecting the chin, what is the reference point? So for females, it is the intercanthal distance. This is the chin that we see. And for male, it is the lateral nasal ala. So in men, the chin is broader while we're injecting. So that's why the points for injecting the chin are different in men and women. Similarly, when we are doing the angle of the mandible, for women, we go from behind because we do not want to broaden the lower face. So we inject from behind like this. And for men, we go sideways. on the bone. Although it's periosteal, but in women it's from behind the angle, and in men it is from sideways, like this. Then for chin assessment, we have these Ricketts line, The upper lip should project forward of the lower lip by 1 to 2 mm. A line from the point of the chin to the... See, this is for theoretical purposes. Practically, I don't know. It's just for reference. You can just have a look at this. A line from the point of the chin to the nasal tip